Today I'm going to be talking about moral distress and the nursing care quality, a correlational study in teaching hospitals. So the main objective of this study was to investigate the association between moral distress and nursing care quality in order to reduce moral distress and increase both nurse morale and patient satisfaction in any kind of healthcare facility. The article explains the domino effect that occurs when employees in a healthcare facility, such as nurses, who sometimes work up to 24 hours to take care of patients. An example, in an ICU unit, they can be there for 24 hours or more at a time. So this explains how their attitudes are critical in defining the level of nursing care quality, which reflects back on the patient satisfaction and experience. Many nurses, especially those in ICU units, CCU units, and psychiatric departments, experience heavy workload, depressing environment, and understaffing. Factors such as these create moral distress, which cause the nurses' caretaking capabilities to decrease. The research questions and framework. Some of the research questions for the study include: is there a significant relationship or association between moral distress and the quality of healthcare services? How much distress do nurses in ICU, CCU, psychiatric departments, and dialysis units experience? So both of these questions address nurses that are in very stressful environments, so ICU, CCU, and psych departments. And they're trying to discover if there's a relationship between the moral distress that the nurses go through because of the stressful environment they work in, and how does that impact the patient's quality of service that they've received? Does the attitude of the nurse really have that much of an impact on the patient? And then the theoretical framework in the article is to establish the theory that moral distress in nurses has a negative effect on the overall quality of care that patients experience. This theory is proposed and then conducted through multiple studies and discussed through the results that were found. The sampling and recruitment. So because the researchers could not find a comparable study, the sample size was decided to be 602. The number of nurses was limited, which led to the researchers using census sampling conducted within 11 months. The steps in recruiting the nurses and getting them to fill out the questionnaire was as follows. So first, the ethics committee had to permit the study protocol, and then the research and technology deputy offered the letter of approval to conduct the study. After the questionnaires were ready for administration, the main hospitals were selected, and then the provisions were made so the nursing managers of the hospitals and the executive officers and the supervisors could hand out the questionnaires to the selected participants by going to the hospitals during every single work shift. So the morning work shift, the afternoon, and the night work shift. And the data collection instrument was a questionnaire, and the questionnaires were collected 3 to 7 days after being handed out. So the descriptive correlational study was conducted in ICU, CCUs, dialysis units, and psychiatric departments. The data collection was conducted with a 3-part questionnaire. So there are 3 sections, included a socio-demographic questionnaire, Corley's moral distress scale, and quality patient care scale. The Corley's MDS entails 3 main areas. So those were namely disregard the patient with 16 items, decision-making authority, 6 items, and professional capability, also 6 items. And these were all used to measure the level of moral distress based on the triggering clinical situation, and that was using a 7-point Likert scale. The highest and lowest potential scores for the Corley's MDS are 30 and 210, scores 30-90, 91 to 150, and 151 to 210, signify respectively low, medium, and high amounts of moral distress. And then the QualPACS consisted of 68 items and assesses nursing care quality in 3 domains: psychosocial with 32 items, physical 23 items, and relational with 13 items. The QualPACS items are rated by 4-point Likert scale, with 1 being never, 2 is sometimes, 3 is often, and 4 is always. For each item, minimum and maximum possible scores are 1 and 4, respectively. For the whole scale, minimum and maximum possible scores are 68 and 272, respectively. Scores 68 to 136, 137 to 204, and 205 to 272 represent respectively undesirable, relatively desirable, and desirable nursing care quality. So continuing with data analysis and collection, the data was conducted through descriptive statistics. This included frequency, percentage, mean, and standard deviation. These were all put into SPSS 13 to help conclude the levels of moral distress and nursing care quality. In order to signify the distress in nursing care quality, a contingency table, also known as the Pearson correlation coefficient, was employed. And then the relationship amongst moral distress and nursing care quality was examined by Pearson correlation coefficient. The difference between moral distress and nursing care quality was in two wards studied by a t-test, and the equality of mean values and variances was inspected through Levine's test. So summary of results. The mean score for the participants' moral distress was 141.89, and that signifies a medium amount of moral distress. From the participants, 52.8% reported to experience moderate levels of moral distress, and 41.3% reported to experience high levels of distress. According to the Corley's MDS, the subjects experienced the maximum level of moral distress while providing care under dangerous circumstances due to inadequate nursing staffing and conditions in which disappointing care was applied to the patients for this reason. So the maximum level of moral distress wasn't what was originally thought to be causing it, which was where they were working in the environment of ICU, CCU, or psychiatric department. It was more so what was going on, such as they didn't have enough nurses working in that department. So that kind of caused them to get morally distressed, and that was what was affecting the patient satisfaction. So the mean score for the nursing care quality was 195.97, which is considered to be relatively desirable, 37.1%, and desirable, 61.2%. by 98% of the participants, and undesirable by approximately 2%. In the QualPACS items, the items, when the patient asks a question, I reply verbally and non-verbally. I ask the patient his or her name before medication administration, and I observe my personal hygiene, were the most often stated items of high quality. 23 of the participants had low levels of moral distress and described to provide care services with desirable quality. Therefore, the nurses' moral distress appeared to have no consequence on the quality of care delivered by them. This assumption was tested by Pearson correlation coefficient, and moral distress and nursing care quality were not found to be correlated. So the original hypothesis that nursing care quality and moral distress were associated is now found to not be associated at all. So there is no correlation between the nursing care quality that's provided by the nurses and how they're feeling morally. And the mean level of moral distress was 137.8 in the psychiatric departments and 142.7 in other study departments that represent moderate levels, 90 to 150. According to independent and paired t-tests, there was no significant difference in mean score for moral distress between the two groups. The mean quality of care was 189.2 in the psychiatric departments and 197.2 in other study departments that represent moderate levels of care quality, so that's the 137 to 204. According to independent and paired t-tests, there was no significant difference in mean score for care quality between the two groups, even though the mean score for care quality was greater in the psychiatric departments. So the summary of discussion, the present study demonstrated that moral distress was not effective on the quality of healthcare services, and inadequate staffing and lack of delivering healthcare services the patient needed were reported to be the most important causes of moral distress. So the nurses were really just getting stressed because they didn't have enough staff on hand, and they weren't able to deliver the patients the care that they really deserved. So that was stressing them out. The effect of moral distress was not patent on the quality of care, according to the researchers' understandings with clinical care and from the viewpoints of nurses who were involved in clinical practice and taking care of patients. Moral distress is diminished when students and caregivers are assisting in taking care of patients, as well as due to lack of essential coordination and teamwork for particular reasons, such as insufficient resources, providing unsuccessful medical care, absence of respect for patients' independence, physician-nurse relationship, and incapability to avoid patients' death, which can indirectly affect nurses' clinical performance and care quality. Answers to the questions. The study did answer the research questions. Moral distress is not effective on any healthcare services. Also, 52.8% of nurses experienced a moderate amount of moral distress, and 41.3% demonstrated high amounts of distress. It is also proposed as a suggestion of what to do to improve moral distress and consequently healthcare services. It is critical to adjust and enforce programs that will decrease tension and develop productive nursing management to deliver and maintain effective nursing employees to encourage nursing care quality. The study limitations. So the limitations on this study was that because it was descriptive correlational, the results are less likely to be generalizable to other communities compared to those of qualitative work. So it's kind of hard to apply to other communities. The study setting can be one of the reasons for which certain factors cannot affect the quality of care, because in CCUs, ICUs, and psych departments, caregivers and family members of the patients are not present, and most patients in those wards are critically ill and they have really small amounts of consciousness. So to ask them a question about their quality of care is kind of challenging because the consciousness is very low. And the inclusion criteria were having at least a bachelor's degree, having worked in the department for at least 6 months, and volunteering to participate in the study. So that kind of made it difficult to find nurses who were willing to participate because a lot of them didn't fit the criteria needed. Conclusions and recommendations. So the conclusion is that the finding of the present study highlights and therefore necessitates the adjustment and implementation of programs for reducing tension and developing efficient nursing management to provide and maintain efficient nursing staff in order to effectively promote nursing care quality. Future studies should be conducted on association between moral distress and the quality of care from both nurses and patients' perceptions, the basis of moral distress and methods to relieve it in clinical practice, the identification and promotion of effective strategies on the quality of medical care, comparison of nurses and patients' perspectives on care, priorities, and quality. And that's it. Thank you so much.